Good evening. I would like to welcome all of you to the Society of Skeletal Radiology Resident Education Club webinar. My name is Jenny Weaver, and I will be serving as the moderator for this session. It is my pleasure to introduce your speaker for this webinar, Dr. Shefali Kothary. She is a musculoskeletal radiologist at NYU Langone Health in New York, where she is a clinical assistant professor in the musculoskeletal radiology division. She completed her fellowship in musculoskeletal radiology and imaging at Hospital for Special Surgery. She has a strong interest in resident and fellow education and mentoring. Her clinical interests and areas of expertise include sports imaging and arthropathy. She serves as the chair for the Health and Wellness Committee for SSR and is a member of the Resident and Fellow Committee in SSR. She enjoys traveling, sports, and cooking in her free time. The topic of her lecture is interesting hand and finger cases. Thank you all for coming today to listen to Dr. Kothary's lecture.
I'd like to thank the SSR for having me today, and I'd like to thank Dr. Weaver for moderating this session. So I have no disclosures. So we'll start with our first case, a 24-year-old status post fall. Okay, so we'll start with our first question. Seems like the majority has said ulnar collateral ligament tear with that quarter flexor pollicis longus tendon tear. Okay, so let's continue on. So our image showed an avulsion fracture at the ulnar aspect of the first proximal phalangeal base right here. Here we have the MRI images. We have proton density fat sat and proton density weighted sequences. So we can see here, this black structure is our ulnar collateral ligament. It's torn off of the first proximal phalangeal base. Right here, we can see the gap. This small low signal intensity structure is that avulsion fracture, and we can see the cortical defect here at the ulnar aspect of that first proximal phalangeal base with some marrow edema within the proximal phalanx. And then similarly on our proton density weighted sequence, we can see that retracted ulnar collateral ligament with that avulsion fracture. So now our next case, our companion case. Okay, so what lesion is associated with an ulnar collateral ligament tear? Okay, we have a few responses saying a center lesion. So let's great. Very nice, a yo-yo sign. We have an avulsion fracture here at the ulnar aspect of the first MCP joint. So we have our MR images. We can see edema here at the ulnar aspect of the first proximal phalangeal base. We're starting to see our low signal, a few strands of our ulnar collateral ligament, this low signal intensity structure, but it's completely torn off of its attachment at the first proximal phalangeal base. We can see this fluid-filled gap right here with proximal retraction of those fibers. We're starting to see this low signal intensity structure. And right here, we see the low signal intensity adductor pollicis aponeurosis with sitting with the retracted ulnar collateral ligaments here proximally. So this is that yo-yo sign that some of you indicated, indicative of a Stenner lesion. Okay, so this case, so the ulnar collateral ligament tear, another term for it is gamekeepers. Or a skier's thumb. Sorry, give me 1 second. Okay, so gamekeepers or skier's thumb, it's secondary to acute hyperabduction injury or valgus injury at the first MCP joint. So it can either be due to that acute injury or it can be a chronic injury due to repetitive overuse. So on radiographs, we always usually get radiographs first. They're often normal, but we always want to look for that avulsion fracture or other signs of joint instability, widening of the joint, angulation, signs of subluxation or dislocation. Then the next step would be to get that MRI, as we saw in our case, to assess the degree of ligament injury, whether it's a partial tear, full thickness tear, if there's retraction of the tendon fibers, and also importantly to look for that Stenner lesion that we saw in our case. If there is a Stenner lesion, that's often going to be indicative for a surgical intervention, as those retracted, as that interposed aponeurosis is going to prevent healing of the ulnar collateral ligament. Okay, so let's move on to our next case, a 40-year-old with finger pain and swelling after injury. So here we can see that there's soft tissue swelling overlying the 5th digit proximal interphalangeal joint. And if we zoom in, we can see that there's cortical irregularity here at the radial aspect of the distal 1st proximal phalanx. So again, our next step is going to be to go to MRI. Here we can see hyperintensity and irregularity of the radial collateral ligament, particularly at its proximal phalangeal attachment. We can see some low signal intensity fibers still at the middle phalangeal attachment. So this is a radial collateral ligament tear at the 5th proximal interphalangeal joint. We again see this low signal intensity structure here that likely reflects a small avulsion fracture. Okay, and on our axial image, again, we can see that tear of the radial collateral ligament. And we can see normal looking ulnar collateral ligament fibers in this case. So it's important to note that at the metacarpal phalangeal joints and the interphalangeal joints, we have radial collateral and ulnar collateral ligaments. And so we can look for tears of either of those ligaments. Okay. So our next case, 25-year-old with hand pain after injury while fencing. So we have our next question: which structure is torn? Okay, great. So it looks like everyone has said sagittal band. So that's great. So this is a case of a sagittal band tear. So here with our red arrow, we can see a fluid-filled defect where in the expected location of the radial sagittal band. Here's our extensor tendon that's ulnarly subluxed. And then here with our purple arrow, we see the ulnar sagittal band. There is some signal hyperintensity in that sagittal band, so there is a low-grade injury, but we do still see some intact fibers. So just to review the anatomy, so here if we're looking at this diagram, this is our metacarpal, our proximal phalanx, middle phalanx, and distal phalanx. So at the level of the metacarpal phalangeal joint, we have the sagittal band. The sagittal band is part of the extensor hood, which is a complex retinacular system. It extends circumferentially around the metacarpal phalangeal joint from the volar plate to the extensor tendon. So if we're looking at what would be an axial image of the metacarpal phalangeal joint, we have, here's our volar aspect, we see the volar plate. Here's our dorsal aspect, you see the dorsal, the extensor tendon centrally. And then we have our two sagittal bands, the radial and ulnar sagittal bands that extend around from the volar plate to the extensor tendon. So if we're looking at a normal MRI image, here we can see our extensor tendon sitting nice and centrally. And then we see our low signal intensity structure radial sagittal band and our low signal intensity ulnar sagittal band. And then in our case, as we had just seen, right, we see that extensor tendon is subluxed with that fluid-filled gap. So sagittal band tears are also known as boxer's knuckle. They usually result from resisting finger extension or from direct trauma. Early diagnosis is important because if it's diagnosed early, it can often be treated conservatively. However, with late diagnosis, then it requires surgical intervention. Okay, great. So let's move on to our next case, a 20-year-old with finger pain after a basketball injury. So click on the abnormality. Okay, great. So we have a few arrows in different places, but a lot of the arrows are here at the dorsal aspect of the proximal phalanx. So that's correct. So here's our low signal extensor tendon, and then as we get to the level of the proximal interphalangeal joint, we see a fluid-filled defect. And so this is a tear of the central slip. So we'll go back to our diagram. The extensor digitorum tendon trifurcates into the central slip and two lateral bands just distal to the MCP joint. So here we had the sagittal band at the MCP joint. So as we go distally, now we start to see the trifurcation into the central slip and then the lateral slips. And then the central slip inserts on the dorsal aspect of the middle phalangeal base right here. So if we're looking at a normal MRI image, again, this is our full extensor tendon, and right here is where we expect the central slip to insert at the base of the middle phalanx dorsally. So in our case, we can now see that there's that tear just proximal to that insertion. We see a few remnant fibers at the phalangeal attachment, but with that fluid-filled defect. So central slip tears are result in a boutonniere deformity. This is flexion at the proximal interphalangeal joint with hyperextension at the distal interphalangeal joint, as we can see in our case. This is flexion here with extension at the distal interphalangeal joint. You may or may not see an associated avulsion fracture. Some of these tears involve the tendon in isolation, and some will cause an avulsion fracture at that dorsal base of the middle phalanx. Okay, so we'll move on to our next case. This is a 44-year-old with finger pain and inability to extend at the distal interphalangeal joint. Okay, so now which structure is torn? Okay, so okay, great. So we had some 100% at terminal tendon. So that's great. So this is a terminal tendon tear. Here we can see again our extensor tendon, and then we see now a fluid-filled defect more distally at the level of the distal phalanx with the retraction of those torn tendon fibers here to the level of the middle phalanx. Here's our axial images where we can see that fluid-filled defect where we would expect that terminal tendon to be. So now back to our diagram. The conjoint lateral bands of the extensor tendon then converge over the dorsal aspect of the middle phalanx to form the terminal tendon or terminal extensor tendon, which inserts on the dorsal aspect of the distal phalangeal base. So now looking at our same normal anatomy image, we can see here the terminal tendon inserting on the dorsal aspect of the base of the distal phalanx. So terminal tendon tears, also known as mallet finger. This is an avulsion injury of the terminal tendon due to forced flexion at the distal interphalangeal joint while the proximal interphalangeal joint is extended. This results in inability to extend the finger at the DIP joint with slight flexion at the distal interphalangeal joint. So again, these injuries can also have an associated avulsion fracture at that dorsal aspect of the base of the distal phalanx. So here's an example of a bony mallet finger where we see here that avulsion fracture, and on a corresponding MRI image, you can see the marrow edema within the distal phalanx with that avulsed fracture fragment and with the extensor tendon still attaching to that avulsed fragment. Okay, so now our next case, we have a 40-year-old with acute pain and loss of thumb extension after injury. So I'm going to scroll through some images and then we'll have the question after that. Which tendon is torn? Great, so we have about 2/3 for our abductor pollicis longus. Okay, now 80%. A few for none of the above. So review again. So here is our tendon that we can see. So low signal intensity fibers, and then as we go proximally towards the wrist, we're losing the tendon completely. So now we're getting towards the just towards the proximal wrist, towards the forearm. And here we have, so this is actually the extensor pollicis longus tendon. So here we can see the extensor pollicis longus tendon inserting on the base of the distal phalanx. And then as we go proximally, we still see some tendon fibers. And then right here, we see that the tendon is hyperintense, irregular, with fluid surrounding it. And then we lose it at the level of the carpal bones. So this is extensor pollicis longus tendon rupture. So the extensor pollicis longus is located within the third dorsal extensor compartment of the wrist. It inserts on the dorsal aspect of the first distal phalangeal base, and it's the primary extensor of the thumb. So with the rupture of this tendon, there's inability to extend the thumb. It's often associated with distal radial fractures, but it can occur spontaneously due to various causes, chronic inflammatory process, multiple steroid injections, or just chronic repetitive motion that leads to tendinosis and then predisposes to tearing. So again, here we see these are just a few select images. This is where we would have the extensor pollicis longus of the third dorsal extensor compartment as it's extending towards the thumb. And then more proximally, we see that high signal within the tendon fibers. And then even in a more proximal image, we lose those tendon fibers with fluid in the expected location of the tendon. Okay, so our next case, we have a 36-year-old with hand pain. Okay, what is the diagnosis? Great, so we have response for Quervain. Okay, and which extensor compartment is involved? Okay, perfect. 100% for the first compartment. So yes, this is Quervain's tenosynovitis involving the first extensor compartment, which contains the abductor pollicis longus and the extensor pollicis brevis. This more commonly affects women than men, and it's typically due to overuse, but it can be due to local trauma. Typically, conservative management is preferred. And here we see that thickening and hyperintense signal within those first extensor tendons with prominent fluid surrounding the tendons. And then as we go to distally, we're seeing again that high signal tendinosis of the abductor pollicis longus and extensor pollicis brevis with surrounding tenosynovitis. So this is consistent with decurvains. Okay. Our next case, we have a 49-year-old with hand pain after injury. Okay, you click on the abnormality. Right. So we seem to be all over the X-ray with this case. So here's the abnormality. A few of you did indicate this. So we can see that there is this lucent lesion within the distal aspect of the third metacarpal, which seems to have these septations within it. And so we go to our MRI and we can see on our T2 fat sat image that there's a hyperintense lesion with these low signal intensity foci. It's well circumscribed, but somewhat lobulated. And then on our T1 weighted image, we see the lesion is intermediate to low in signal. And then on post-contrast image, we can see peripheral enhancement with some internal septations, which are enhancing. So this is an enchondroma. It's an intramedullary cartilaginous neoplasm. It's the most common primary benign bone tumor of the hand and wrist. It's actually often an incidental finding. In our case, the patient had an injury, which is why it X-rays, and this was an incidental finding. If the patient is symptomatic, it's important to think about a pathologic fracture. There is possibility of malignant transformation into low-grade chondrosarcoma, but this is very rare, especially in the hand and finger. And we're looking for that rings and arcs appearance of the cartilaginous matrix as it ossifies. Okay, so now we have a companion case. Again, we see this lucent lesion now in the fifth distal phalanx, and we see this linear lucency. So this is actually a enchondroma with a pathologic fracture. On our T2 fat sat image, we can see extensive bone marrow edema pattern within that distal phalanx. We see the hyperintense enchondroma. And then on our T1 weighted image, we can actually see that low signal intensity fracture line. So this patient actually went on to have excision and curettage of that enchondroma with bone graft placement. So we see here that this is where they put in the bone graft, and we still see a little bit of that fracture line. And then 2 months post-op, we start to see incorporation of that bone graft and healing of that fracture. Okay, so our next case, we have a 52-year-old with a painful finger mass. So I'll just have you look at these images for a minute, and then we'll move on to our question. Okay, so what is diagnosis? Okay, so we have few of all the answers, but majority of the answers are glomus tumor. So looking at our case, we see this hyperintense mass at the dorsal aspect of the distal phalanx. And then on our post-contrast sequence, we can see that it's enhancing. And here again on our axial images, we see this small rounded mass at the dorsal aspect of the distal phalanx, which is T2 hyperintense, T1 mildly hyperintense to intermediate in signal with avid enhancement. Post-contrast, these are subtraction images, so really brings out the enhancement. And now we have a companion case. Here again, we see that a T2 hyperintense mass at the dorsal aspect of the distal phalanx, deep to where the expected nail would be. And then on our X-ray images, we can actually see bony remodeling of that dorsal aspect of the distal phalanx, and a little bit at the ulnar side of the distal phalanx as well. So this is a glomus tumor, as many of you indicated with the question. So glomus tumor is thought to be a hamartoma arising from the glomus body. It's going to be in that subungual location, which helps to make the diagnosis. And clinically, the typical presentation is a painful mass, which is sensitive to touch and sensitive to cold temperatures. It's more common in women than in men. Radiographs are often going to be normal because a lot of these masses are going to be small, but as they grow, and given the size with time, you can see that smooth erosion of the subjacent distal phalanx, as we saw in our second case, can get cortical thinning on X-rays. And then MRI is going to be used to make that diagnosis, and the key imaging findings we're looking for is a T2 hyperintense mass that demonstrates homogeneous enhancement on post-contrast images. Okay, so our next case is a 52-year-old with a slowly enlarging finger mass. So what is the diagnosis? Okay, great. So we have most answers are for either tenosynovial giant cell tumor or giant cell tumor of the tendon sheath, PVNS. So here we have on our T2 FAT-SAT image, we see a hyperintense mass that's in close proximity to the extensor tendon. It's intermediate to predominantly intermediate to slightly hypointense on T1 weighted sequences, and then there's enhancement on the post-contrast sequences. Again, this is just showing that proximity to the extensor tendon. So as many of you indicated, this is a tenosynovial giant cell tumor or giant cell tumor of the tendon sheath. It's closely related histologically to PVNS. So these are often firm masses, but they're usually painless and slow growing. And as we said, they're in close proximity to the tendon sheath, which helps to make the diagnosis. And the other thing to look for is the presence of hemosiderin. So this is where gradient echo sequences can be helpful in making the diagnosis in order to look for those deposits. Okay, great. So our next case, we have a 28-year-old with a bump on the finger. So here we have our X-ray image. We see this mass here at the ulnar aspect of the fourth middle phalanx that looks to be somewhat continuous with the cortex. Then we went on to MR images. So we can see on our T1 weighted sequence that the mass is somewhat hyperintense with this peripheral low signal intensity rim. And it again looks to be contiguous with the cortex, but doesn't show definitive medullary contiguity. On our T2 fat sat image, we see that the mass is predominantly hyperintense with that peripheral low signal intensity rim, and we see the low signal intensity within the mass. And then on post-contrast sequence, we see that there's heterogeneous enhancement. So this is a bizarre periosteal osteochondromatoma proliferation, or a BPOP, also known as a Nora lesion. It's a benign exophytic osteochondral lesion. It's typically seen in the hands and feet. It most commonly occurs in young patients between 20 and 40 years old. It's contiguous with the underlying cortex, but typically not with the medullary canal. It's slow growing. And these are typically excised surgically, but they often reoccur after excision. And sometimes these can be difficult to differentiate from other kind of lesions, like more aggressive lesions, like an osteosarcoma or a chondrosarcoma, which is usually why they take them out. Okay. Our next case, we have a 29-year-old with finger pain and stiffness. So we have some responses for inflammatory, rheumatoid arthritis, gout, erosion. So we can see on our T2 fat sat sequence, we can see bone marrow edema pattern in the base of the proximal phalanx. We see this cortical erosion, and we can see synovitis at the metacarpal phalangeal joint. So this is a case of psoriatic arthritis, but yes, inflammatory arthropathy. So now we have a companion case. We have a 29-year-old with finger pain and stiffness. And here again on our X-ray, we can see cortical erosion. We can see bone marrow edema pattern in the base of the proximal phalanx and in the metacarpal head at the MCP joint. We can see synovitis. And then actually looking at our sagittal T2 fat sat image, we can see synovitis at the proximal interphalangeal joint as well. So this is a case of rheumatoid arthritis. Now our last case, we have a 61-year-old with finger pain and swelling after a laceration injury 1 month ago. So in this case, we can see this severe joint space narrowing at the third distal interphalangeal joint with overlying soft tissue swelling. We can see bone marrow edema pattern within the distal phalanx as well as within the middle phalanx along that distal interphalangeal joint. We can see joint effusion and synovitis, and then we can see this extensive soft tissue edema around the finger. On our T2 fat sat image, we see a similar appearance as a proton density weighted sequence, and then on our T1 weighted sequence and proton density weighted sequence, we can see T1 hypointense signal, again along the margins of that distal interphalangeal joint. So this is actually a case of osteomyelitis or septic arthritis. It is important to have the history when we're looking at these cases, because sometimes inflammatory arthritis, septic arthritis, inflammatory arthritis and osteomyelitis, septic arthritis can both be in the differential when you see that prominent edema in a periarticular distribution with a joint effusion and soft tissue swelling. And so that does help us to make the diagnosis. Okay.
Thank you, Dr. Kothary. That was a very nice review of a lot of pathology that we see in the hand almost every day. There is a question in the chat box, and the question is, if there's high signal in the tendon, how do you tell if it's tendonitis, tendinosis, or a partial tear?
Okay, so typically the way I was taught, we don't use the term tendonitis so much anymore. So we're either going to talk about tendinosis or we're going to talk about a tear. And if we're talking about tears, it can either be partial thickness or full thickness. So tendinosis, you're typically going to see the tendon to be thickened with intermediate to hyperintense signal. With a tear, you're looking for some kind of disruption of the tendon fibers. Often it's going to be linear, it's going to be more hyperintense than what you would see with just tendinosis, and you would see a defect in the tendon. It can sometimes be difficult when you're looking at a partial tear, but what I'm really looking for is that very bright T2 hyperintense signal with disruption of the fibers. If some of the fibers are still contiguous, then you'll call it a partial tear. If it looks like there's complete discontinuity, then you want to call it a full thickness or a complete tear.
I agree, and that's how I do it. And I tell my residents it's sort of a continuum from tendinosis to partial tear to complete tear. We don't have any other questions right now. If anyone would like to add some to the box, that would be great. Oh, here's one. When are stress views of the thumb obtained of the thumb MCP? I've read it can create a stentor lesion, so it should be avoided. But without it, how can instability be evaluated on a radiograph?
So, we usually leave it to the orthopedic surgeons when they want to do those stress views and when they don't. But, a lot of times on x-rays, when you're just looking even at a static image, you can see that asymmetric widening of that metacarpal phalangeal joint, either at the ulnar margin or the radial margin, depending on the tear. And so I'll look to see that sort of asymmetric widening, the way that we can sometimes see with some of our other joints, if it looks angulated, if it looks sublux, like if the metacarpal head and the phalangeal base don't align. So those are some signs that we can see that instability.
Okay. We have another question from the audience. There is no sagittal band in the thumb. That's a question. Only the ulnar collateral ligament and radial collateral ligament. And also, what is a volar plate injury, and is it always associated with an ulnar collateral ligament injury?
Okay, so typically when we're talking about the sagittal bands, we're looking at the 2nd through 5th metacarpal phalangeal joints. The volar plate is its own structure. I know if we're looking at all the structures of the hand and finger, I was thinking about, volar plate, but there's so many small structures. But yes, so that's usually going to be obviously on the volar side of at the joints. And you'll see this low signal sort of triangular structure, and volar plate injuries do occur in conjunction with other injuries at the joint, other soft tissue injuries at the joint, but they don't necessarily always have to be associated with an ulnar collateral ligament tear. You can see it, but you don't necessarily see it all the time. Okay, great.
The next audience member says, thank you for the nice presentation. When you are looking at an MRI of inflammatory arthropathy, do you usually also comment on the ligaments surrounding the fingers, which may have inflammatory signal? And how do you know if they're torn or that's just reactive signal?
I mean, usually I'm thinking that, if they have an inflammatory process going on and they have not had a concurrent injury, then often that signal is going to be related to the inflammatory process. So usually I'll just comment on whether there's a tear or not because a lot of that signal is just going to be reactive from the inflammatory process that's going on, and not necessarily an injury of the ligament itself. Because mostly when we're talking about the ligaments, we're talking about, when we talk about radial collateral or ulnar collateral ligament, we're talking about the integrity of the ligament as an injury to the ligament itself. So again, that goes back to if you are the part about if there's a tear, you're looking for that discontinuity of the ligament fibers, whether it's partial or whether it's complete. But most of the time when I'm looking at these inflammatory cases, it's often not with a concurrent injury. So, I'm not usually talking about it in terms of a tear, but obviously I'll look at the ligaments. And if there is some kind of discontinuity, then you want to discuss that.
Okay. Another question, in the last case, I believe of septic arthritis, the audience member is asking that they didn't see marked T1 diminished signal. So why did you consider the possibility of osteomyelitis?
Well, so there was, may have not projected well, but there was a little bit of T1 low signal. But that being said, if there's a high clinical suspicion, when you can have in early cases of osteomyelitis, the first thing you will see is the bone marrow edema pattern without the T1 low signal changes. So in that case, it can become a little bit difficult to make the diagnosis. So you would want to still have it in your differential. It could be reactive edema, but it could also be early osteomyelitis. So, if I clinically, they had high suspicion for osteomyelitis, and you just see edema, you still want to at least mention that this could be early osteomyelitis and keep that in your differential along with reactive edema.
I agree. And then maybe we'll finish up with one last question. When you are doing, say, an MRI of a certain finger, if I came to your radiology department and say my index finger had maybe a trauma to it, what kind of protocol do you do, and how do you optimize your protocol so that you get a really good look at these small structures?
So, what's nice about the imaging of the finger is a lot of time we do have clinical history of whether they've had an injury, which finger was involved, is there a mass? And so, as you can see in a lot of the images, that we tend to get small field of view images. Feel that when you are looking at pathology in the finger, you want to make sure that you have that small field of view. It really helps to evaluate these smaller structures a lot more accurately. So number one, I would say, make sure to do that small field of view. Also, the text will put up, you can instruct your text to put on markers around the mass, not over the mass, but, I like to tell them to put it above and below the mass so you're not compressing the structures, which can, again, make these smaller lesions hard to diagnose. And then you can see that, a lot of the sports cases, ligament tears, soft tissue injuries, we tend to do the proton density weighted sequences, proton density without fat saturation and then with fat saturation. And then when you're want to evaluate the marrow signal a little more, like in the case of osteomyelitis, that you want to have that T1 sequence, or if you're looking for a fracture, then the T1 sequence is helpful. I have noticed sometimes that in the fingers you don't get good fat saturation. So if that happens, then you would at least want to have one stir sequence that will help with the fat saturation.
Great. Thank you. So again, I'd like to thank Dr. Kothary for that wonderful review of all of the different things we can find wrong in the hand and fingers. I'd like to thank all of the audience members for listening in tonight. I'm sure that you guys learned a thing or two. And also like to thank the SSR for hosting us tonight. The next session of the Resident Education Club webinar will be on axial spondyloarthritis, and that will be presented by Dr. Alexander Merkel, and that will occur on April 16th of 2025 at 7 p.m. Eastern Time. So thank you all and have a good rest of your evening.